Kathryn's going to be talking to us today about Algin, which is a new filler, non-hyaluronic acid. Kathryn is a GP and a medical director of the Real U Clinic, and she started her injectables in 2004. She's 20 years of medical experience and 13 years in the non-surgical injecting arena. Yes, so welcome, thank you.
And we're going to have a presentation first, and we will leave about 5 minutes for questions at the end. So please, if you got questions, write them down, and at the end we get the opportunity to make it a bit more interesting. Okay? Thank you.
Thank you everyone for coming to my talk. I hope you've had a nice lunch, and welcome. Thank you for everyone for coming to my talk. Hope you've had a nice lunch and welcome. I'm hoping to give you some nuggets of knowledge, so to speak, in the next 20 minutes about a new filler that's come to the UK called Algin. So it's really giving a recap of my experience so far. So as Sharon and Beatrice just said, I'm a GP, I work in West London, and have my 2 aesthetic clinics in Surrey, and started those in 2004. And I specialise in injectables. My disclosures today is that I'm acting KOL for Algin, but I have no other associations with any companies or products I mentioned today. And just thank David Hicks for inviting me to speak today, and the organisers of Aesthetic Medicine Live. So with so many fillers on the market, why do we actually need another one? So Algin has arrived, and what's different is that I feel it's very important, it has no BDDE, and you might think, well, what is BDDE? But I'm sure you've all heard of it. It's the constituent that's the binding agent in all of our readily available hyaluronic acid fillers. It stands for butane diglycyl ether, which is a bit of a mouthful. But Algin has no BDD in it. Algin is natural, which is an attractive thing in today's market. It's less expensive, so for all of us running cosmetic businesses, we have to be aware of this, and that's actually very attractive. It has very good tissue integration, and so it means that we can be confident to put it in various areas of the face with good results. It's a new innovation, and I always think that's exciting to be open-minded to different things on the market. It's good to offer patients another choice, and more I'm seeing in my clinic patients asking me, what do I suggest? But they're also becoming very more well-read with YouTube and TV programs and magazines and special aesthetic publications for the consumer. So they're actually very well informed, and will come and surprisingly ask very educated questions. So it gives the patient more choice in what they're going to have. It's nice to have another tool in our practitioner's toolbox. So I thought this was quite a fun slide. It just demonstrates that we have many hats in our role as running cosmetic practices. We're business people, got to make the books balance. We're doctors, dentists, or nurse practitioners, and highly trained, but we have a medical eye, so we're looking at the skin in a 360 approach. We're artists, which is the fun bit, being able to sculpt and reform and recreate beauty. And we're teachers, which is my role today with you all. So a few statistics I thought I would allude to. The ISAPS organization in the USA stands for International Society of Aesthetic Plastic Surgeons, and they're the only body that collects data for surgical and non-surgical treatments. And they tend to be about 2 years behind before they publish their data, which is a bit of a I'd like to have had a bit more up to date than 2004, but this is really just to demonstrate that Botox has the share of the market, just under 5 million treatments worldwide, 2014, and hyaluronic acid just over 2.5 million. Calcium hydroxyapatite radiesse and poly-L-lactic acid down on the list. So you can see that the big boys are the injectables, toxins and hyaluronic acid worldwide. In the UK, these statistics 2010, the market showed £2.3 billion spent from the consumer for surgical and non-surgical treatments. And 2015, just 4 years later, it's grown to 3.6 billion, which is a 60% growth in the area, which confirms this certainly is an area of financial growth. And non-surgical treatments encompass 75% of that total. And the survey that this body did suggested that 75% of patients that have had one non-surgical treatment would actually be open to having another non-surgical treatment, which means that we're probably doing something right and not scaring them off. This just shows that the optimal age for treatments is between age 35 and 64, and then it tails off after that. So in 2014 it was the US that were the global leaders, and the UK came down on the list, but we're getting there. This slide just to illustrate the current range of fillers on the market. So we have the HAs, which we all know, Restylane, Juvederm, Bellatero and Perfecta. Then we have the HA with the amino acids, which is TSL. There's a new filler, a very exciting filler range called Nuvia. It's a Polish-Italian collaboration, which also has amino acids in it. Stylage with mannitol. Collagen stimulators, as we know, Elance, Radiesse, Sculptra. And a new one that's not on the market yet, Eternigen. Chris Inglefield has quite a bit of experience with that. The Organic Fusion filler range, that's Nuvia. And the Agarose, which is Algin that we're talking about today. So what makes Algin different from all the rest? No BDDE, very important. It's natural. It's got a very good safety record. Highly biocompatible. It's actually fully biodegradable. It's broken down by our macrophages in our skin, and then it's further broken down by the pentose cycle of our endoplasmic reticulum. It's actually then excreted in the liver and the kidneys. It's got great tissue integration and moldability. You'll really appreciate that when you start injecting it. It feels good. It's active at the point of injection, so it doesn't migrate. I think that's important. Where we're putting it is where it stays. It actually comes in a larger dose of the syringe. It has a 1.4 ml syringe, giving us 40% more in the syringe compared to our usual 1 ml that we're used to dealing with. So I find that really quite attractive. Highly competitive in pricing. And it comes from the little old red algae. So this is where the natural portion comes about. And it's a polysaccharide, it's a sugar, but it's not an HA. It comes in 3 varieties. There's the HD, which is the thinner one, the VL, which is the medium grade, and the DF, which is the more robust one in the range, shall we speak. The lower one, the HD, which is used for the finer approach, does not have any HA in it. But the other two, the VL and the DF, do have HA, a very small amount, and it's not cross-linked, hence no BDDE. It's bound to sterile saline. That's just a photograph to demonstrate when you open the pack you have 2 syringes and a little what we call ergonomic grip to attach to the syringe. You've got your dating stickers and a little diagram. And it comes with a lure lock, which is already in place, 2 syringes. You agitate the agarose gel about 20 times between the 2 syringes, and then you effectively activated it. This slide just demonstrates the importance of the consultation in discussing what we're going to use with our our patients. And younger ladies are particularly interested in the natural approach. I got very good reception with a lot of ladies, particularly the younger ones, who were particularly more interested in what they're eating and how they're running their lifestyle, and also quite keen on the red algae approach. I'd like to show you some of my experiences before and after photographs. This is the HD, the thinner one of the range. An example of this lady, interesting case. She's in her late 40s. I've used numerous HAs in her, increasing the G prime as I've gone along, because it's basically been a failed HA lady. Her body tends to just eat it up, and she's very unsatisfied with it. So she's been waiting for an alternative, and she gets a lovely result. This lady is in her early 40s. She's had dietary problems, anorexia over the years, early menopause. Her collagen in her skin is trashed, and her perioral lines and skin texture is really quite poor. She just wanted some light rejuvenation, and was really pleased with the result. We could do more, but she was happy. This lady is in her late 50s, works in a cosmetic counter. Makeup is her be-all and end-all, and she wanted her lips to look better when she sells her makeup products. Happy with the result. This lady has various medical conditions and collagen loss, quite extreme, but just to demonstrate the fine lines can be easily improved with the HD. There is erythema, but these pictures are taken immediately after. Algin SVL is the medium grade. Now you will see this lady, looking at her, you think she doesn't need anything to do with her lips. She's a young lady, she was on a mission, and she said, I'm not leaving till I have something, which we all come across. So I put a small amount of VL, probably about 0.3 of a mil, and it gave a really lovely result. She was happy, and I didn't even have to use much at all, so good result with minimum product. This lady, delighted with the result. The shape and the volume was much improved. And this lady, too many sunbeds, too much smoking, not an optimal healthy lifestyle, significant nasolabial folds, but I think a great result. Very natural result for a very naturally beautiful lady, nose to mouth lines. Just a bit on Algin DF. This is the big brother in the range. Good for cheek augmentation, as you can see with this lady. Lovely, smoother, more volume cheek. She was happy. Nose to mouth lines, and some work on some of the oral commissures, and skin texture has improved. This lady is in the mid-30s. She jogs and exercises excessively, hasn't got much fat on her face, and as a result, a lot of skin folds. But the Algin DF was definitely the one for her, and delighted we could revolumize her with such a good effect. This lady, I'll show you, we had a complication with this lady, which I'll allude in another slide, but her end result was really good. She still has some bruising on the left side. One of my mentors in my journey with Algin is Dr. Adriano Bertoli. He's a maxillofacial surgeon from Italy, and he very kindly has lent me some of his photos to share with you. So he uses Algin HD in the lip, beautiful result. Algin HD, again the thinner one in the range, for oral commissures and perioral rejuvenation. Fine lines around the mouth. I think can't dispute that's a lovely result. So I thought I'd just tell you about the pitfalls of and useful tips. We have Algin does sting a little bit, more so than an HA, so I call it the ouch effect. This is probably because there's a little pH change. It's not 100% neutral. It ranges from 6.8 to 7.7. So there is a possible need to mix it with a little bit of sodium bicarb. There is a bit of swelling and soreness, which can last for up to 72 hours. It all settles very nicely, and need time to massage and not rush this treatment. Use small amounts. A linear approach is good, and avoid big boluses. Don't inject it rapidly because it's quite fluidy compared to the gel consistency of an HA. choose your patients wisely. It works best, I find, on patients that have got some fat on the face, not those that have just got skin hanging. And review them 7 to 10 days later. Just to show you that some people do react to their fillers a bit more than others. Their skin sensitivity, sometimes you can't judge this if they say they don't have eczema or they don't have aren't any other medications, no pre-existing skin problems, but they just have sensitive skin. And this lady, luckily, the redness just resolved within an hour. That's immediately post-injection. This is a lady that I showed you had an excellent result before, but she's my patient, my one complication. So I used DF, that was the stronger one in the range, and she ended up with a significant swelling within 48 hours, heat, redness, pain. I treated her for infection with antibiotics for 5 days and some oral steroids. And I think it was an infection and an inflammatory reaction. What I've learned from everything settled beautifully. What I've learned from this case is that I injected probably 1.5 syringes on each nasolabial, so it's 1.4 plus half of that. And I think in hindsight I wouldn't inject that amount in future. Just go a bit slower, get them back and do it in 2 stages, there's no rush. Remember your emergency kit, which you've all seen before, and just to remind you, it's very good to photograph patients when they're having a complication, and then again in follow-up. Always have your emergency kit. Cosmetic pharmacy actually has a beautiful kit. I think it's on offer at the moment in their stand, and it's an all-in-one job in the kit. So just keep calm, keep calm, and keep open-minded using Algin. My clients have had some very good testimonials. I won't go through those for the interest of time. It's different, it's moldable. Watch out, it stings a bit just for the first few seconds. It gives a beautiful natural lip, less inflammation, and it's an alternative to an HA, but it's not a replacement. In conclusion, it's new and exciting. It's got a very good safety record, over 10 years being used in the maxillofacial industry in Italy with no granulomas. It's modern, it's not permanent, and it's unique, no BDDE with red algae constituent. Don't run before you can walk, take time to learn about this product. Physician's Guide is out now, sorry I'm going through this quickly now. And we have some teaching, the first teaching in Wigmore in March. You're most welcome. Thank you for your attention.
Thank you, Kathryn. Don't go, because hopefully we got some questions.
Hi, could you just explain why the others have BDD in them and what it does and why it's important not to have it?
So BDDE is a bit of a mouthful. It stands for butanediol diglycyl ether, and it's the common binding agent in the HA. So you've got hyaluronic acid molecules, but you've got to have something to bring them all together and make that gel. And in the market to date, there's been just one binding agent available and commonly used in all the large manufacturers. And now I think with the evolution of trying to improve safety and make fillers better in the future, manufacturers have looked at how can they improve the constituents and make things last longer, less inflammation, natural results, and good plasticity, viscosity, and the whole works. And they found that replacing BDDE with another component or leaving it out can help reduce the inflammatory reactions that come across with the current range of fillers that we've been using historically. I've certainly had cases, actually more prevalent in recent years, where I can't explain it, but we do a filler and then it could be 3 months, 6 months, 2 years later, they'll get a tonsillitis, for example, and the lip augmentation product will swell up as though it's in sympathy. Or another case where a lady had gastroenteritis after having a dodgy fish meal, and her cheek augmentation started to swell up. I've looked at this and thought, I don't want to be harming my patients, because it's happening maybe a little bit more common than I'd like. is there a missing link? Is there an immune reaction that we're not appreciating? So I think that anything that is tackling BDDE in the future may help reduce those. That's why I'm open-minded to it.
We got another question over here, first.
Kathryn, some of us may remember Novabel, which was an alginate based filler. The problems they had with that were that there was no way to break it down, and subsequently there were some very nasty side effects and problems for patients. This appears to be very similar. Can you outline how it's going to be different from Novabel and whether you've got something to take it down if you have a problem? Thank you.
Thanks, it's a very good question. It was probably my first question when I went to the initial training. I was quite a big Novabel user. I loved it, particularly in the tear trough areas, but I think it came to bite us in the tail, the people that used it enough really. Novabel is quite different from Algin. Novabel's from brown algae. Algin is from red algae. Novabel is a alginate and Algin is a agarose. So the different, it's like salt and sugar. However, one would think, oh, you need to have an enzyme like Hylase to dig us out of a hole with this filler. But this filler would respond quite well to injecting any potential lumps with sterile saline and a warm compress and fairly heavy massage, ideally in the first 2 weeks after the lumpiness has been detected. So that has a good result. And there currently has not been any need for an enzyme to break it down, and many syringes have been sold and used over the last 10 years in the Max and dental industry in Europe.
Okay, one more question.
Kathryn, it was just really to touch on what Sharon has just said, really, with her experiences with Novabel. Obviously, I was bitten with Novabel myself. Are there any areas where you won't be using this filler?
So, really good question. I think that this filler, you have to be more mindful of the depth of injection and walking before you run. Get used to the HD version. I find you can do a lot with the thinner one in the range. When I went to my training, Adriano from Italy was very keen to say, you know, you'll be keen to do the lips with Algin because it gives a fantastic result. Don't go putting VL until you know what you're doing, or choose your patients wisely, because you just want the HD does a beautiful result. Also, it smooths out very nicely. You just need to inject it slowly and massage it really well.
Kathryn, I understand it's not hydrophilic like HAs, and I'm very used to HAs, and so I bear in mind that my products are generally hydrophilic when I inject them, and therefore I don't overcorrect. How would you assess how much product someone would need based on really what you inject is what you get? It's not going to change, is it?
Good question. And in the guidance note and from my training and my observations is that I've been taught to just inject to the point of correction of that defect. Comparable to hyaluronic acid, sometimes we over-inject because we have a degradation of the product on massage, and it tends to go down after a few weeks. Our patients can come back a bit unhappy. But with the Algin, you inject to the point of the defect resolution. You can always get them back in 7 to 10 days later and do a top-up. I know sometimes we just like to, we have busy clinics, we don't want to necessarily clog up the system and get them back, but it will pay dividends, particularly when you're learning with this one. I do find that it does swell, but it only lasts for 72 hours, and that's not the hydrophilic portion that's doing that. I think that's our inflammatory immune reaction, because we're putting something in the body that hasn't been there, the body doesn't know what's going on, so it comes to its defense. But that's it.
So I can get to what you said that, for example, you're doing a lip, where you need, what is your average volume if you're doing a lip to get some of the results we've seen there?
You wouldn't need 1.4 mils.
1.4.
No, you wouldn't. You probably need, just like we would use an HA, maybe.
Like a ml.
Yeah, or 0.8, maybe a little less. Yeah.
So that's simple with the sleeve. And if you're feeling a line or wrinkle, that's straightforward. But what about when we're talking these days about lifting capacity, and if you want to recreate a lifting effect, which obviously a lot of people are using now, videos, or you're using some hyaluronic acid fillers for that. How will you compare?
So I would, for the lift, I would use a VL initially until you've got really used to the product, and then the DF, and you'd be particularly good on the zygomatic arch. And a bit like Radiesse, you're injecting supraperiosteal, deep.
Excellent. Any other questions? So we obviously got one last, and we got 1 minute later. We can ask more questions at the end.
Yeah, I just want to ask you, because you said it is usually quite a deep injection. If you want to use it to correct a nose, for example, what would you use?
The nose is not on the indication, so I personally wouldn't recommend it in the nose.
Excellent, well, thank you very much. Stay with us because later there may be more questions. So.